Good morning, everybody. We'll just take a minute here and let everyone get settled in, get signed on, and then we'll get started this morning. But I'll go through a few housekeeping things while we wait. So I just wanted to let everyone know that today we're going to be having our webinar here on pelvic health in Parkinson's. The webinar will be recorded, and I want to thank Sailaja for joining us this morning. I'm Bree, one of the client service coordinators with Parkinson's Association of Alberta, and I'll be moderating. If you have questions while we're going through the webinar, please put them in the chat below. So that's the little chat icon somewhere kind of bottom of your screen, typically towards the middle. This will let you type out your chat or your question and put it in the chat, and we'll do questions at the end of the presentation today. This webinar, like I said, is going to be recorded. All information provided in the video by Parkinson's Association and our featured speaker today is furnished strictly for educational and entertainment purposes only. Service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, and/or care of your physician. And general questions at the end about symptoms, treatments, and available like medications, other healthcare therapies, and current research in kind of the pelvic health field will be fielded. So I want to welcome, and that's Sailaja Pammidi. I hope I got I'm sorry if I got your last name incorrect. Please correct me. And that,
No,
but
this is Sailaja Pammidi.
oh, Pammidi, perfect. Well, it's a beautiful name.
Thank you.
Well, born and brought up in India, graduated with a bachelor's in physiotherapy in 1998 and a master's in psychology in 2004. Has always been passionate about neurology and has practiced in neuro specialty and multi-specialty hospitals for 12 years in India before moving to Canada in 2010 and started working in QE2 Hospital in Grand Prairie since 2014. After working in different specialties, moved to neuro and medically complex outpatients in 2016 and started the journey into the Parkinson's world in 2016 and got certified in Parkinson's Wellness Recovery in 2017. And our first group program for Parkinson's clients was started and is still ongoing there in Grand Prairie, which is so exciting. And working closely with both Parkinson's and MS clients for nearly a decade, and has helped kind of explore and learn about things that affect these populations and training in things like vestibular rehabilitation and pelvic health. So welcome, Sailaja. I'm so excited to have you here today. What an exciting topic, and I'll turn it over to you to start so that we kind of get as much information as possible.
Thank you. Thank you. Hello, everyone. So today we're going to be talking about pelvic health, an important but often overlooked part of Parkinson's. So I'm trying to keep this as practical and gentle and confidence building a session than anything else. And as Bree said, we will field all the questions in the end about any specific symptoms you want to talk about that is relevant to this particular topic. So, as I said, I'm Sailaja, and I currently work with QE2 Ambulatory Care Center as a outpatient neuro. At this point, I'm only seeing MS and Parkinson's clients, and we have about 120 active clients on our caseload, and we see about 70 or 80 a week in here through different group programs that we offer. This is a very exciting topic for me, and I started dwelling into this more and more as I started talking to my own clients. And when I say refer them to a pelvic health therapist, they're very reluctant because it's such a vulnerable topic. Some are very embarrassed to talk about or think about it. Then I felt like probably I'll be a better person to address this because I've already developed the rapport and the trust with my clients. And that's how my journey into pelvic health started. So here is the most important thing. Why pelvic health matters? It's not just for Parkinson's person, for any individual, it does matter a lot because it's about comfort, it's about confidence, and it's about daily independence. If this dictates how comfortable am I going out of the house, and do I have to plan everything around it? Do I have to go just in case? There's a lot of those things that go around in our brains when we talk about bladder leakage or bowel incontinence and stuff like that. So it's about comfort, confidence, and daily independence. And Parkinson's affects the nerves that coordinate bladder and bowel function. That's just the nature of the disease. It's nothing like it's faulty on your side or anything. It's just how the Parkinson's affects the nerves that coordinate the function. But talking about it helps reduce stigma and improves quality of life. So if there's one take-home message from here, talk about it. Because when you talk about it, it opens the doors for solutions. So what is pelvic health? When we talk about pelvic health, it's such a very broad global name, but what does that actually include? It's about your bladder health. It's about your bowel health. It's about your pelvic floor muscles. And it's also about the nerves that coordinate everything together. So everything needs to work together as a team to have a healthy pelvic functioning. The pelvic floor, this is how the pelvic floor looks. It's a pelvis is where you're sitting on, and it's like a ball. And in that ball, you have all the pelvic organs that includes your bladder, right? It includes all the pelvic floor muscles that actually creates like a hammock holding all of these structures in. So it provides support for the pelvic organs. It assists in maintaining your bladder and bowel continence. It's like a valve because it has to open and close for us to empty and void and all that stuff, and close to prevent that leakages. Ability to allow the passage of full-term fetus and sexual function health. So how does Parkinson's affect pelvic function, right? That's what we're going to kind of focus more on. Because if I go into the anatomy of the pelvic health, it's going to be such an extensive topic. An hour is not going to be enough. So how does Parkinson's affect pelvic function? Is the slower or disrupted nerve signaling. You all know what Parkinson's does to different muscles in our body. We move slow, we move small. And it doesn't affect just our arms and leg muscles. We connect more to it because that's what we see. But everything inside us, whether it's the heart, whether it's the bladder, they're all muscles as well. But they're unseen, so we don't connect it with the same dots as we connect our arms and legs moving slow. At the end of the day, they are muscles. They also act slower and they also act smaller. Right? So slower or disrupted nerve signaling, muscle contracting or relaxing at the wrong time. That's where the coordination is. And if they're not coordinating well enough, and there's a mixed match signal coming from the brain, instead of relaxing the bladder, it may contract it, making it hard to void. Or instead of contracting and closing the valve to prevent flow, it opens it, then you end up with leakage. Right? So that's another thing. And medication side effects. Yes, medications are good for Parkinson's, but we all are aware every medication comes with its own side effects. Right? And then reduce mobility affecting bathroom access. Again, we move slow, the shuffling gait, being depending on assisted devices like walkers and stuff, the space that is available for you to navigate, the speed with which you're able to take those big strides and walk, all of that mobility issues do affect the journey from where you are to the bathroom. And if it's not quick enough, then you do end up with having leakages and accidents and stuff like that. So the common symptoms, bladder symptoms in Parkinson's that are most common, one is urgency. I need to go now. That kind of an urgency, right? Frequency, you have to do bathroom visits more frequent because we are not emptying it at all at one time because of that the coordination issues and stuff. You may empty half the bladder, but 10 minutes later you feel you have to go back again. So that increases the frequent visits to the bathroom. Nocturia, nighttime urination, and that's very common, and that affects your sleep. Which affects your sleep means you're more sluggish in the morning, the brain fog. It also affects how your medications are actually getting absorbed and all of that stuff. So it has got and fatigue. Fatigue is a huge factor. But if I don't get a good enough sleep because I'm pretty frequently getting up to go to the washroom, and for a lot of clients that I spoke, it's just the anxiety alone makes it worse. Because okay, I may have to get up this many times to go to the washroom. That keeps playing in the brain is what they keep telling me. And incomplete emptying, as I said, and leakage. These are the most common bladder symptoms that I have heard from our own Parkinson's clients. So it's just a quickie one. So bladder statistics, urinary symptoms at 24 to 96 of percentage of people with Parkinson's. You may wonder why it is 24 to 96%. It's because a lot of times it's not actually addressed because people don't talk about it. So most of them gets unreported. If everybody gets reported, it could be 75 to 96%. So that's why I put 24 to 96 because of not getting reported enough, not getting talked enough. Okay. Overactive bladder is especially common. The bladder that is like overly acting, that's what makes you frequent urgency and frequency. That's what creates it, the overactive bladder. And women report more pelvic symptoms than their peers. Just because pelvic organ is such an important aspect of the woman's life, given the pregnancies and childbirth and menstruation cycles, that's one area that's part and parcel of women. So it's not they don't feel I feel as embarrassed to talk about it as the counterparts. So that's why it's reported more in women than in men. Why bladder symptoms happen, as I was telling you, it's the neural pathways, right? The overactive bladder muscles. So again, bladder itself is a muscle. It's a smooth muscle, but it's still a muscle, right? If it's not contracting, if it's not receiving that signal from the brain properly, and the signal gets interrupted somewhere, then the bladder is just going with the sensation it feels rather than the what should be from what the signal should be doing, right? Pelvic floor not relaxing fully, and as I said, delayed brain bladder communication and fluid intake patterns, right? A lot of times I hear people think, I know what to do, but the brain tells me what to do, but my body doesn't want to listen to it. Or my body is not receiving the signal from the brain, though I know what it should be doing, right? So that's the delayed communication, or this is the interrupted communication that also leads to all these bladder symptoms. So that's bladder. Now we're going to move on to our bowel symptoms in PD. Constipation, the most common symptom in Parkinson's. Hard stools, slow gut movement, feeling not finished. Like I had gone to the bathroom, but I don't feel I emptied it completely. There's always feeling that emptying is not complete. And then urgency as well. Urgency is not as common, but constipation is definitely the most common symptom. And so when you come to the statistics of it, constipation, as I said, 40 to 50%. Again, the numbers are low here because of not being reported enough, not being talked about enough. Some studies indicate close to 80% of people with Parkinson's do have constipation. Can appear years before an actual diagnosis happens. So all of you, if you had gone to the when you see your neurologist, hopefully everybody would have all filled out the form, which is the non-motor symptom scale for Parkinson's. This is the scale that actually looks into all the non-motor symptoms the Parkinson's people go through. Not about tremors, not about rigidity, not about posture, not about gait. Here we are talking about the non-motor symptoms like your sleep disturbances, loss of taste and sense of taste and smell, constipation, restless legs, falling asleep, trying to fall asleep, or difficulty staying asleep. So these are all the non-motor symptoms we are talking about. And this is a huge one. And it's proven statistically and research-wise, non-motor symptoms sometimes even occur 10 to 15 years earlier than an actual diagnosis of Parkinson's is made. So if you go back and think, you will say, okay, yeah, I've been constipated. I've been constipated all my life. Or I've been constipated since my early 20s and 30s. Like you hear this all the time. Oh, I didn't think I had the sense of taste for a long time, but I didn't think about so much about it, right? So, but because it's constipation, again, is such a global symptom, why would I relate constipation to Parkinson's? we will think, okay, it's because I didn't drink enough water today, because it's been a stressful period, or it's because I hadn't had enough fiber today. That we give ourselves a lot of reasons. Who would think constipation is Parkinson's at that earlier stage, right? But then it becomes what it is. And I said, and it's typically linked to lower gut movement. And when I say gut movement, my biggest thing I always kind of harp about is your abdominal breathing. It's your diaphragmatic breathing. We all sit there and just take a deep breath. You'll see it's more your chest moving than your abdomen moving. Can you all take a deep breath for me and see where is your breath coming from? Is it coming from your chest or is it coming from your tummy? Is your tummy moving at all? The reason why I say that is if you're not engaging the diaphragm, you're not engaging the abdomen, which is where all your deep core muscles are situated, it also is not allowing your gut to move the way it should. If the gut does not move, it's not pushing your fecus down the long chain of the intestine and colon and all of that stuff. So that also means there's hardened stool stuck all through, or you're constipated, right? So that's why for me, for the first line of action, if somebody asks me with pelvic health, I'll self-correct the breathing pattern to start with. That would be my first go-to. It's always looking into the breathing patterns. So why bowel symptoms happen? As I kind of already spoke about, it's the slower gut movement, right? My gut is not moving well. It's not pushing because it has to go the whole, if you see the picture, you can see how many angles there are from the point of where it gets formed to where it gets ejected. So if my gut is not moving fine, there's so many areas it can get stuck. So emptying is never full. There's always remnants left, which also can lead to infections later on, bowel dissections and whatnot. But that gut mobility is the most important thing. So slower gut movement, less activity, because Parkinson's itself slows you down and gets harder to move and move at a certain intensity for the gut to move as well. So less activity, not enough fluids or fiber, and medication effect again, right? So all of these are the most common ones. So I don't want to overwhelm you with a lot of other scientific medical info. This is the most common things that Parkinson's clients go through that I've come across. And this is what impacts their life the most. And how does it impact? Is one is the interrupted sleep, because frequent urination means you're getting up so many times more in the night to visit the bathroom. So it's interrupting your sleep cycle completely. Worry about accidents, right? Because if you can't make it to the bathroom in time, obviously we are leaking, which means we are having accidents, which could potentially lead to falls as well, right? Because there's leakage and there's an accidents and all that stuff. And ultimately what happens if this keeps going on, then we are not socially confident anymore, because we need to plan everything around it. I want to go there, but I'm afraid I'm going to embarrass myself because I'm going to leak or I'm going to have an accident. I'm going to have it. And it's true for every one of us. It's not just because you have Parkinson's or not. That's how it is. I went through that after my second child for a little bit. It's very common after pregnancy as well, having that urine leakage, stress incontinence, and all of that stuff. And it is like I have all the plans, but I cancel it in the last moment because this is a factor that keeps niggling in your brain. What if? Right? And that's quite normal. That's quite natural. But one thing I want to say is it can be helped. And then medication absorption issues. So that's another thing. Apart from the breathing, why am I so interested in gut motility or gut mobility? It's not just about Parkinson's. The Cinemet or levodopa, carbidopa, whatever medications you are on, most of the Parkinson's medications that you are on gets absorbed in your small intestine. right? And for it to get absorbed properly into the bloodstream, your gut motility needs to be good, which means you can't be constipated. If you are constipated, the medication is not getting into the bloodstream to the amount of dosage you're taking it. Maybe only about 15-20% of it is entering the bloodstream, and the rest is just getting stuck in the gut, which also means the efficacy of your medication is reduced by almost 75 to 80%. So you don't get the full benefits of that medication with your mobility. And we think it's because we are not on enough dosage. So typically what happens if we do not bring up the topic of constipation with the doctors, whether it's a neurologist or anybody, they would think it's probably we need to increase the dosage rather than addressing the issues of constipation, hardening stools, and gut motility. Increased dosage, is it effective? For a while, yes. But it's going to be in the same vicious cycle one more time. So you can't keep increasing the dosage. We need to find ways to make the dose that you are taking is being effectively used to its fullest capacity, right? So that's the reason when I say, when you see the doctor, don't talk about dosage, talk about how can we get the most benefit of the dose you're on. Talk about your constipation, find ways to deal and treat that aspect of it because it's the most important aspect for your medication absorption, right? So these symptoms affect more than just the bathroom. They influence our energy levels, our mood, and our daily routines. And that's why it's very important that we address this. So that's the good news. As I said, it could be helped. The reason I say think about it this way, let's simplify it. You do exercises for your arms and legs because we believe the muscles can be trained and retrained, right? It's the same thing with your bladder. It's the same thing with your heart because they are muscles as well. The muscles can be strengthened. The muscles can be trained. They can be retrained. They can be re-educated. And that's why there is success. And there's definitely success. It could be slow. To start with, it could be one step forwards, two steps backwards. It could be a lot of trial and errors as what works best for each client. But at the end of the day, it's a muscle. So it can be trained, it can be strengthened, it can be modeled and to work the way you want it to work. All right. So bladder management strategies, how do we work with this bladder? We have these issues. What do we do to help train it better so we are not always thinking about it, worried about it, and stuff? Timed bathroom visits. It's about habituation, right? Timing your bathroom visits. So I'm going to go how many times with this after every 2 hours or after every 3 hours, just kind of sticking to a schedule. I know it's easier said than done, but habits have to be built. It doesn't happen in a day. Rather than habits getting built, habits are very hard to break. We all know that. But you also need to understand, brain understands patterns. That's how the brain works. It understands patterns. How many times we make it home before we realize we made it home without a thought process of how we made it there. Because our brain works on an automatic pilot because it's so patterned that we just get there without even having to put a very cognitive effort into it, right? So brain always recognizes patterns. That's the reason why repetitions matter. With any exercises, that's why the rep matters because the repetitions is what creates those neural pathways. You're all familiar with the word neuroplasticity. So what creates that neuroplasticity? Because at one point, they compared a brain to a plastic. What can plastic do? It can mold to whichever way you want it to mold. So repetitions at a certain intensity and doing it consistently does change your neural pathways, does train these muscles to act in a more coordinated and efficient way. So that's why habit building is important. So that's why I put it there as timed bathroom visits. Reduce caffeine / frizzy fizzy drinks. I did not put pop because even your carbonated water, though does not have sugar in it, is still fizzy. They do affect, they can be bladder irritants. And that's why I put it as fizzy drinks and not as pop. Okay? More fluids earlier in the day, not after 7 o'clock. Restrict how much of water you're drinking. So if you have to drink 2 liters of water, I would say the 1.5 needs to be before 7 o'clock. And the rest of the 500 ml from 7 till your bedtime, so that it increases that the nighttime urination. And pelvic floor exercises, that's a whole big aspect of it. And then clear path to the toilet so that there's nothing obstructing your way from getting from your bed or from your couch to the bathroom. Don't have to go through all the clutter, the loose rugs and whatnot, right? Healthy bladder habits. So when I said timed visits and how often, so how often should a person empty their bladder? With normal drinking, one should void every 2 to 3 hours during the day. That's normal. Should go no longer than 4 hours between voiding. It's not just for Parkinson's clients. All the spouses who are there, caretakers who are there sitting and listening to this, it's for every one of us. It's for Bree, it's for me, it's for my family, every one of you. It's not just for people with Parkinson's. This is just healthy bladder habits, period, for every person. And voiding once during the night is considered normal. If you're wondering how which is normal, which is not, more than that is not. If you're getting up more than once to go to the bathroom in the night, then we need to really think about what is happening and why. Okay? How much fluid should a person take in during the day? 2 to 3 liters typically, right? And is it a good idea to do just in case? Definitely no. But we all have that habit. I want to go to the shop, or a mall, and I know I'm going to spend there some time, and I hate visiting those toilets there. Or just let me go, just in case, Before I head out, take my car out to drive to Edmonton, let me go because it's just in case. I'm going to be road for another 4 hours. Just let me go just in case. That's not normal because you, as I said, every time you go visit the toilet just in case, that's the signal you're sending to the brain. And every time you prepare something, the brain is going to tell you, go to the washroom, whether you need it or not. Those are the patterns and habits we are talking about. Okay? So, as I said, 8 to 10 glasses per day. Too little water irritates the bladder. And as I said, is it a good idea to go just in case? No, this can lead to go too often, reducing your bladder capacity and also increasing your urgency, plus giving those mixed signals to the brain. So no just in case. All right, these are just some of the things like irritants that I kind of put in there. If there's something here that feels, oh, I am guilty of that one. If there's one thing you can take out starting today, go for it. So one is the caffeine. That's the biggest culprit. Caffeine comes in various forms, not just having coffee. So when you think about caffeine, don't think just about coffee. Think about everything that has got caffeine in it. Alcohol is the second most bladder irritant. Smoking, spicy foods. For some people, it's tomatoes and citrus. It's different for every person. I'm not saying these are global for every individual, but these are the most commonly recognized bladder irritants, and that's the reason I put it out there. For me, spicy food, I can't exist without it. It's just from where I'm coming. I need my spicy food. So I probably will have more water just to get that irritants flush out of my system. But that's what it is. And as I said, carbonated beverages, we don't think about carbonated waters as in the same lineup as pop and things, but they do affect your bladder. And fluid intake, as I said, 7 p.m. if you have that overactive bladder symptoms. So these are just simple ones. Just urgency suppression. How do I do that? Is like stop, you sit and you breathe. And then perineal pressures, that helps sometimes if I have to go, but I don't want to go because it's not too, let's just put me, now I'm kind of putting a schedule like every 2 hours is when I'm going to visit the toilet. But at a point of 1.5 hours, you feel the urge to go. Now you need to learn how to suppress that urge because I don't want you breaking that day. Oh, one time is fine. I'm just going to go an hour and a half because the one time is going to become a second time, third time, and we break the habit. How do I suppress that urge, right? So that's where your pelvic floor muscles come into action. That's where the pelvic floor muscle training come into action because it teaches you how to hold, how to suppress. So that's the perineal pressure. Just putting your hand around that area and then putting a little bit pressure helps in suppressing that urge to go. And then, as I said, pelvic floor muscles, squeezing those pelvic floor together. And if you want to know where your pelvic floor muscles, we all think we know where they are. Honestly, let me tell you, we don't. If you all want to know where your pelvic floor muscles are, if you have a pool noodle or a towel, roll it and put it as if you're sitting on a saddle. Put it between both your butt cheeks and sit on it. Then you'll know exactly where your pelvic floor muscles are or your perineal muscles are. Okay? So these are just some of those. Now let's go talk about the bowel. So bowel management strategies, things that help. One is warm drink in the morning. Fiber-rich foods. We have known this for ages, how fiber is so very important. Hydration, again, harping about the same thing, water and water and water and water. Movement, very, 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 very important. And abdominal breathing help with gut mobility. So these are the most important things that we need to think about. And how do we get all these ducks in a row so that my bowel is getting proper management it should and be healthy. So a healthy bowel habits, increase fiber in diet, typically about 25 grams per day is what is recommended. They come in different aspects. Most of your greens and most of your water, cucumbers and all of that stuff are very high fiber. Good bowel habits, obey the first urge. Okay? Because if you don't obey the first urge and you suppress it at that time, you're kind of sending a different signal to your brain one more time. It's all about how we are signaling the brain and having the brain coordinate things for you. So if you get the first urge to go and void, even though it's not complete, go for it. And good positioning and no straining. So I'm just going to leave it there. Sit on the toilet and relax. Don't be anxious about it. Relaxing is half of it because to void, your muscles need to relax. The more tensed you are, the more stiffer you are, the more tight you hold your body, you're sending a signal to the brain saying everything needs to be held in. So that's why relaxation is such an important aspect of it. Feet always supported because that helps in your pelvic floor muscles to actually sit and relax. Spine straight or lean forwards a little. The leaning forward little is basically to provide that extra abdominal pressure that would help in voiding. Knees together or knees wide, doesn't matter. For some people, it has helped when they do that knee in, knee out, knee in, knee out. It helps the pelvic floor to move and it helps in voiding. Don't push to pee. And same thing with your bowel. So blow into a closed fist instead of straining to pass the stool. So if you have to strain, if you feel, rather than bearing down or pushing down, trying to just blow. Try that. Blow into your closed fist and see what happens down there. You feel that gut wanting to move. That helps that pressure, build that pressure a little bit more and helps you to pass the stool rather than straining. These are just simple strategies. So no hovering, no straining. And the sitting posture is very important. I know at one point, so if you're sitting the way in the first picture, if you see in the regular way, there is that kink, if you see the kink in the first picture, the sitting posture. But if you can go into a squatting posture using a squatty potty or something like that, it actually takes the kink away. So it's a straight down. And so it makes the voiding the stool much more easier. So squatty potty, it's a very important tool. If you haven't explored it, it's worth, all my toilets have them, and I haven't had it for ages. Plus, the roots I'm coming from, we didn't have Western toilets for the longest time. Western toilets became a thing after people started visiting Western countries and seeing how easy it is to be on a Western toilet for the hips and knees and stuff like that. But until then, it was all squatty potties. So if you haven't already used it, it's worth a try. Pelvic floor therapy, what does that do? What do the pelvic floor therapists do? They help in teaching you how to strengthen those pelvic floor muscles, but they also teach you how to relax those muscles so you can void completely. They focus on your breathing and posture because that's very, very, very important. And it helps in time, it helps with your urgency, leaking, and constipation. So pelvic health therapists help women and men who have problems with urinary and bowel or bowel incontinence, people with pelvic organ prolapse, pelvic pain, painful intercourse, pregnancy-related conditions, postpartum recovery, and more. Are they any different from a regular physiotherapist? No. Physiotherapists help with all of those things. The only difference is we have additional training and more focused training in these organs in this area. But most of the therapists have the knowledge of how the body works and how the systems work. The only difference is we have additional training in specific areas of pelvic health. And probably have more tools in our belt when it comes to assisted devices that can help you and stuff like that, more information regarding all of that. Plus wanting to know more because we are invested in this area. We're always constantly learning. We are constantly reviewing papers, what the research is saying, what's come out that's helping better than before. So we are constantly in seeking knowledge. That's what makes a pelvic floor therapist specifically different from a PT, a regular PT. Helpful equipment, raised toilet seats. It helps with your easy mobility and stuff like that. Grab bars, of course, with balance and stuff. It doesn't hurt to have a bedside commode if there's a lot more frequent visits happening that's leading to accidents and leakages and stuff. It's okay until you get help and you get them trained. Bedside commode is an option. Absorbent pads, again, as I said, like the reason I put temporary, these are all should be, especially the bedside commode and absorbent pads should be thought about as a temporary solution when you're working to get yourself stronger. They're not a permanent solution. If you take them as a permanent solution, then you are getting more and more dependent, which means you're not moving enough anymore, which in the long run is even worse. Clothes easy to remove. When do I seek help? Frequent accidents due to leakages or rushing to the toilet and falling and stuff. Pain or burning when you're either peeing or going to the having a bowel movement. No bowel movement for several days. Or feeling unable to empty. So underreporting is very common. As I said right in the beginning, many try to keep these symptoms private due to embarrassment. And let's be honest, pelvic area is such a vulnerable area. It is vulnerable to talk about. It's vulnerable to be examined for. It's just one of those topics that's just vulnerable. And that's the way it is. But keeping them private is not helping you either. You are not getting the help that you should be getting and you deserve to get and have a better quality of life. So talking about, as I said, then opens the door to solutions and better quality of life. So I'm glad you actually signed up for all this. That shows you're willing to be helped, willing to talk about it, or at least start thinking about it. So thank you for showing up. So hopeful takeaways. As I said, these issues are very common. There are so many strategies that would help. Small changes become the biggest building blocks. And then before you realize it, you have more confidence and better quality of life. And remember, you're not alone in this. Any questions? That's about it.
No, that is wonderful. And I do have some questions, but even
Okay.
I learned a couple new things and some bad habits that maybe I have as well. So this is very informative. So I do have some questions from the chat here. So first one I have, so how can one tell the difference of bladder symptoms that are related to Parkinson's and other bladder related issues or prostate related issues? So this one's specifically asking about benign prostate hyperplasia / prostate cancer in men. So, like, how
Um,
might someone tell the
so
difference between the symptoms?
it's very hard to tell the difference of symptoms because symptoms could be similar for both of them, but the causative factor is different. So
Hmm.
whenever we talk about symptoms, we always need to look as to what is causing those symptoms. Because if you're truly treating something, we should never be treating the symptoms. We should be treating the cause of it,
Hmm.
right? So if, the biggest thing would be actually seeing a therapist who can do an assessment on whether this women and men. For women, most often it's the pelvic floor prolapses after pregnancies and stuff. So they do a proper assessment to see if it is because of a prolapse or an hyperplasia that's causing, or an enlarged prostate that's putting pressure on, and all that stuff. And then if it is the enlargement of a prostate that's putting pressure, then that's the treatment that needs to be addressed. That's the thing that needs to be addressed.
Hmm.
But if that's not causing any pressure on the bladder, it's not big enough or it's not enlarged enough, and then we can still, like symptom wise, we can still treat it how we would treat any other symptom, like doing the timetable and all of that stuff. But the cause still need to be treated.
Hmm.
So you're always treating the cause, not the symptoms. We address the symptoms, but we treat the cause.
Hmm. Excellent. Thank you. Um, so I have someone, they have IBS, and they asked if there's anything different from what you suggested kind of throughout the presentation that you'd suggest specifically for someone with IBS.
With the irritable bowel syndrome,
Hmm.
if it is an established diagnosis of an irritable bowel syndrome, you are already on some kind of a treatment for it,
Hmm.
right? What we're talking about here is, again, is that irritable bowel syndrome. What are your symptoms? What is that causing you? Is it incontinence, or is it constipation, or is it a mixture of both?
Hmm.
Like, and then how did we change our eating habits and intake habits because of the irritable bowel syndrome, and how much of that could be a potential irritant versus not? So this is something that you have to do, again, as I said, a symptom checklist and correlate it with IBS and see if they match, and then
Hmm.
go about treating those symptoms and that particular issue.
Excellent. Someone had heard about rocking kind of gently back and forth on the toilet as something to help with emptying. Is
Relaxation.
that true? Yeah, to
Yes.
relax.
Yes. Yes.
Excellent.
A lot of times, rather than what is suggested is, rather than bending forwards, people actually, it's easier to lean back if you can, if you have room, because that straightens the kink one more time and helps. And as I said, moving your knees in and out will also help that pelvic floor muscles to act and contract in a certain way. And then, as I said, blowing into the closed fist, all of that helps with avoiding in a better
Hmm.
way than just sitting there and trying to strain. And if it's still a hard stool, what do I do? Because I've heard people who say once every other time they have to put a finger through the anal opening to pull that hard stool down and all of that stuff. But what you can all, yeah, I know. But what can help is just putting that pressure in front of your vaginal opening and the back rather than inside, and then just giving a little squeeze. That also helps in getting that hard stool down. And if you have fissures, because sometimes it happens that we tend to bleed because our skin is so frail, and the hard stools can cause bleeding around that anal fissure area because of the skin cracking and all of that stuff. Vaseline does help.
Hmm.
So even taking the Vaseline on a bud and wiping, putting it around that anal area and a little bit inside helps that gives a little bit more moisturizing or a lubricant effect that the stool can pass a little bit more easier than not.
Mm-hmm. No, that's good to know. Someone
Hmm.
asked about they wear an abdominal binder for blood pressure issues. Might this have an effect with the bathroom issues because it's putting pressure like across like the abdomen and bladder?
They have an abdominal binder for blood pressure.
Blood blood pressure, yeah. So low blood pressure, so it helps the pressure helps bring the blood pressure up for them, but
Hmm.
it's putting pressure across like the abdomen.
It would, because if they're going to have it too tight, and again, I don't know who prescribed that. That's a very specific question.
Mm-hmm.
Honestly, I'm not going to give an answer to that other than
Mm-hmm.
saying like who prescribed that abdominal binder, what's the mechanism behind it? Because what happens is increased abdominal pressure does play with your blood pressure. And a lot of times, orthostatic hypotension is a very common symptom in most Parkinson's people. And that's the reason with different positions, some people feel off balance and may feel dizzy and all of that stuff. So if the doctor specifically gave an abdominal binder to keep the blood pressures up, the thing is, which is more important, is what it's going to come down to.
Mm-hmm.
If I take the abdominal binder to go to the washroom, is that affecting in that little span of time that I'm there? Is it affecting my blood pressures drastically that I need to keep it?
Mm-hmm.
If you haven't tried it, that's one thing you can probably talk to the doctor and try it and say, okay, now when I'm visiting the bathroom, I'll take the belt away, but I can measure my blood pressure before and after and see how much of a drop it actually created.
Mm-hmm.
It hasn't done anything to my blood pressure during that period of me going to the washroom and avoiding, then probably that's a good solution to have is take it off before the bathroom and then put it back right away. But if there's
Mm-hmm.
a big difference, a jump in the blood pressure, but that's a conversation with your doctor.
Yeah. Excellent. I've got a couple more here. So, is there a role for Botox in incontinence, like bladder urgency and incontinence?
I have never heard about it. Botox actually being a thing. Botox does help with spasticity.
Mm-hmm.
And spasticity is not such a common symptom with Parkinson's. Rigidity is. And
Mm-hmm.
typically, they are given, Botox is given to the moving muscles like external. So I don't know because, and your bladder muscle, such an internal one. So
Mm-hmm.
if for people with spasticity and they have like lower abdominal spasticity, which is very very rare. Actually, I've never had anybody with MS or stroke ever have an abdominal spasticity. But that's where it comes down to which muscle are we going to give the Botox to help in relaxing those muscles.
Mm-hmm.
But I've never heard about Botox being a factor with constipation.
Mm-hmm. I've got one. So you mentioned in kind of what can help with bladder issues
Mhm.
and bowel issues, the pelvic floor exercises. There's some examples of those exercises of what that might look like or be that people can
So okay, so you're all
practice.
sitting, right? You're all sitting there. All I want you to do is sit with your legs supported and have them shoulder width apart. And sitting there, just try and contract your P muscles without holding your breath. So pull it in where you're trying to say, I'm going to stop the P.
Mm,
So pull them in. And when I say pull them in, I want that muscles, only that muscles. You don't should be feeling any pressure in your abdomen. You shouldn't feel any clenching in your butt cheeks, but you should be able to just activate and pull only those muscles. Is it okay if I stop sharing the screen and then I?
yeah. Oh, yeah, of course.
All right. And I'm going to spotlight myself. Is that okay?
Yeah.
All right. Hello, everybody there.
There.
I'm
Perfect.
sitting here, right? And without clenching my butt cheeks, without clenching this, can I actually just clench my P muscles and so like trying to stop the P? And can I hold it there for a few seconds and let it go? Important aspect here is not just clenching the P muscles, but not holding your breath. A lot of times when we begin, when I say don't hold your breath, breathe, they let go the contraction as well. Right? That's one thing that definitely helps. And you all heard about pelvic bridging. You all should know what that is, right? So it's basically you're laying on your back, you have your legs bent, and you lift your hips towards the ceiling.
Oh. Mm-hmm.
That's again, it's the same thing, clenching your pelvic floor muscles or your P muscles in and not arching the back and lifting your hips towards the ceiling. And a lot of times I think about telling people, think about you riding an elevator. Sit here and you clench first floor, clench again, moving to the second floor, clench again, moving to the third floor. You won't see any habit. If I'm clenching my butt cheeks, you'll see that movement happening, but that's not what I'm doing.
Mm-hmm.
You see the difference? Clenching my butt cheeks and everything. That's not what I'm doing. I'm just clenching my P muscles or my pelvic floor muscles slowly. First floor, I stop there, pull again. Second floor, I stop there, pull again. Third floor, I stop there. So climb as many floors as you can before you have to let go.
Mm-hmm.
That's talking about control. How do I control how much of pressure or how much of pull and how much of closure I need to get? So that helps with the control of it. And when you reach the top, it could be fifth floor for some, it could be fourth floor for some it could be just the second floor. It's okay, that's where you're gonna start. Once you reach there, hold it without holding your breath and see if you're able to hold it. Every time you leave your breath, if your muscles relax, then we have work to do. Does that make sense?
That's very good. That and it's
So,
something that everyone can kind of practice and use to gauge a
yeah, so,
little
so
bit
there's
where
so
they're
many
at.
strategies, very simple strategies that we could do just laying on the bed, just sitting on the table. It's not a very sophisticated exercises. They're very simple, but we don't think about. One is because we forget where our deep abdominal muscles and pelvic floor muscles are. Half of us do not have an awareness of it. So that's why when I said, I'm just going to be back once.
Yeah. While she's doing that, I can describe abdominal breathing because I see that in the chat there. So abdominal breathing, so like what she was talking about at the start, when she asked us, do you feel it like your chest expanding or your stomach expanding? So abdominal breathing, when we take proper deep breaths, we want to engage the diaphragm. So when we breathe in, we want our
So,
stomach to push out. And so we deep breath in. We don't want just our chest moving. We want our abdomen moving as well. So that's that abdominal breathing. So you can feel it pushing out when we take that deep breath in, pushing in when we breathe out.
so here's the towel. I just rolled it, and I'm going to put it right between my both butt
Mm,
cheeks, like a saddle.
mm,
Try sitting like that, then you'll actually appreciate where your pelvic floor muscles are. Now, after doing that, now try to contract. If any of you want to just get up and get it and try it, go ahead. And then try to contract your you'll always feel the difference. You contract it better. One, because there's an awareness of where they are,
mm,
because
mhm,
that's a sensory feedback for you. And you have something tangible that you're gonna contract against. That also makes it much more accessible and easier to understand which muscles am I contracting versus trying to imagine where they are and what I'm trying to do.
mhm, mhm. That's excellent. Perfect. Someone has a question. Is bowel incontinence something that's common in Parkinson's?
It's not as common as the bladder incontinence is common,
Hmm.
not the bowel as much.
Mm-hmm.
Yeah.
And then one, so if urinary incontinence issues continue or urinary urgency issues continue, should they consult like their family doctor or like would a urologist be the best person to see for kind of continued
So
bladder issues?
technically, what we suggest if any person comes to me for a pelvic health, especially with bladder issues, whether it is urge incontinence, whether it is stress incontinence, or it is urgency, or it is a combination of, most commonly I've seen is it's a combination of stress and urge incontinence.
Mm.
What we start off with is a bladder diary. We do a 3-day bladder diary where we put all our intake of fluids and the output. What this does is to identify how much of water we are taking and how much we are avoiding, and the frequency, and how much of them could be considered potentially bladder irritants. And it
Mm.
also helps in building that habit, right? This is where we start. But to know the reason behind it, and we need a proper investigation, like I said, from people, it is the prolapse, the pelvic prolapses. It could be the prostate, overacting and all that stuff, or enlargement of the prostate. Then they need to be properly investigated in a proper way.
Mhm.
Yeah. But your first step could be a pelvic health therapist.
Mhm. Excellent. Speaking of the irritants, I have a question here. So you mentioned the irritants there in the presentation.
Mhm.
Should they like just cut all of these irritants out? Is it figuring out what irritates their bladder specifically?
Yeah. So I'm definitely not for someone who say take this out of completely, because it doesn't work that way.
Mm-hmm.
I don't believe in crash dieting. I don't believe in sticking to a certain diet. I believe in eating everything that I love to eat, but in moderation. So I
Mm.
never say cut this out completely, especially caffeine is such a hard habit to break. And when you consider caffeine to be the number one irritant, if I say all of you are here today, make a decision that you're going to quit drinking coffee, how many of you are actually going to do it?
I'll speak for myself.
I see the zeros there. So it's
Mornings.
not going to happen. The reason why the bladder diary would help here, especially, is how much of caffeine am I taking? Some people have the habit of getting up in the morning and having a cup of coffee at 6 or 7 o'clock. They have one at 11 o'clock. Then they may have a tea at 4 o'clock, and they have something else with caffeine before bed. We don't know
Mm.
until, because everybody's habits are so different. And I say, when caffeine, as I said, caffeine is not just in coffee. So even just doing a very generalized a day or two of bladder diary will give you that idea as to
Mm.
how much of it is actually water. Yes, I'm having fluids, but out of that, how much of it is actually water and how much of it is coming from other sources,
Mm.
whether it's juice or tea or coffee or all of that stuff. When we talk about juice, is it fresh pressed juice at home? Or is it out of the packet? How much of sugar is involved in it? That is not coming from the fruit itself. So there's so many aspects of it, right? So that's where I say, if nothing else, start your own bladder diary.
Mm. Mm-hmm.
I can
No,
send out
that's
the sheet.
excellent.
She can send it all to you all if needed, or you can just Google it saying a bladder diary. It's going to come up, and you can just have your own little assessment tool there.
No, that's excellent because it
And
is one of those ones.
are you
It's
going to
intimidating to
completely
cut
take it
things out.
out? I never suggest completely taking anything out.
Hmm.
Moderation helps.
That's excellent. And then, kind of following along in the irritants one, I have one last question here. So, is there certain things that people might be like individually more or less sensitive to? So they might not be as irritated by something
Yeah,
like spicy
totally.
food, but caffeine really
Yeah,
bothers their
totally.
bladder. Okay.
Totally. Totally. Because as I said, every individual human body is so very different.
Mm.
And where we come from matters, because spicy food doesn't affect me as much as it would affect my friends who are not used to it. Because for me, my body is accustomed to it. May not be affecting me as much as it would do any other person, right? It's the
Mhm.
same thing. Caffeine may not be affecting them as much as it would me, because I'm not used to caffeine.
Mhm.
Because I've never tasted coffee or tea so far. So I never got into the habit of it. So I don't know how it would affect me. So even if I'm a trail runner. So even if I'm getting any energy boosters, I have to go for a non-caffeinated one, because I don't know how caffeine would affect me.
Mhm.
You know what I mean? So it's so very different from each and every person. So it's going to be a lot of trial and error. It's like maintaining that diary, maintaining that adding foods and deleting foods to identify which is the most effective for you.
Excellent. No, that is fantastic. It's all the questions I've got. I'm just double checking the chat. Yeah, I don't see any more new questions in here. This has been so informative. I mean, I've learned so much, so I hope everybody else has learned lots as well.
Hope it did
And
help.
yes. I-
I will give my contact information. Bree should have it. I probably should have added it.
Mhm.
You're all welcome to email me anytime if you have questions or
Mhm.
anything that you really want to discuss as a one-on-one basis.
Mhm.
Feel free to.
That's
You can
excellent.
always
Well,
organize a virtual one-on-one visit as well.
yeah, that is fantastic. Well, thank you so much for your
Very
time today and
welcome.
sharing your wealth of knowledge and information with us. And on behalf of everyone here and Parkinson's Association, thank you. And
Thank
thank you
you.
for everyone who
Thanks for
joined
having
us
me here,
today.
and thanks for joining and for all your time.
Yes.
Bye
Well,
bye.
take care, everyone. Have a lovely day.
Thank you.